Yes.
Dr. McClelland, I want to ask you a little about some of the arrangements for donor sessions. In general, were the sessions that were held in the first half of the 80s and indeed throughout the 80s, were they predominantly call-up donors or drop-in sessions, or was it a mix?
Throughout the time I was there, I think the proportion of new donors was always around about 20%. I can't actually remember the figure, but it was always, quite a smallish proportion of the total number of donors. The remainder were people who were repeat donors, and we certainly latterly defined a repeat donor as somebody who had given within the past 2 years. After that, they were called a lapsed donor, some of whom came back. But if they came back after 2 years, they were subject to the same procedures as a new donor.
If you needed more donations, if you had in a particular month, say, some concerns about shortages, how quickly could that be achieved, and how would you go about achieving it?
I don't recall that we very often had to do a sort of urgent call. It would have been, the method would have differed through time. In the early days, we were really very heavily dependent on community donor organizers, and we probably would have called on one or more of the community organizers who we knew had big donor panels and would be able to motivate people relatively rapidly. We also certainly did, I think from quite early on, we used local radio quite a bit, and that was quite an effective way, particularly if there was an event that explained the need for more blood. In fact, that could be overwhelming. When the Gulf, was the Gulf War? I can't remember. I think it was the Gulf War. We were overwhelmed with donors, and it was difficult to manage the sessions.
Now, I'm going to ask you to look at a document which gives some information about donations in the first half of the 80s. WITN 6666025. You'll see this is an annual report, essentially covering 1984 and into early 1985. If we go to page 10 briefly, we see in the second paragraph the heading "Blood Mobile arrives." That's June 1984. That, I think, is a reference to what had been recommended or mentioned in the inspection report. And in your response, you'd said that the arrangements were underway, but it would take some time.
Yeah, it took much longer than we'd hoped, but yeah, that's it.
And then if we turn to page 25, we've got information there about donor attendances and donations in the period 1973 to 1985. For present purposes, I'll just take it from the table at the bottom of the page. And we can see this doesn't include plasmapheresis donations.
No.
So we can see, is this right, an overall increase in both attendances and, unsurprisingly, donations in that period of time covered by this table. And if we look in particular at 1983, 1984, 1984, 1985, so the last two items in the column donations, that's the period during which the AIDS leaflet began to be in circulation. We'll obviously explore that in more detail in the course of the afternoon. It doesn't look as though there was any drop-off. On the contrary, you were managing to get increased attendances and increased donations.
That's correct. Although there was a couple of years later, I've got some more figures here actually, and I've seen a chart of it quite recently. I think there may actually be a chart of this in my witness statement somewhere. But 1 or 2 years after that, there was quite a sharp fall in donations, and I think we interpreted that as the message about AIDS beginning to get through to the public and people being more concerned about it. So, cause and effect is difficult to establish here, but certainly the immediate effect of the first, well, that would be the first 18 months really of the leaflet in its various guises, didn't seem to affect our Southeast donor attendance, and I don't think actually there was much shift in the SEBTS, in the whole of the SNBTS. I printed it out so small that I can't actually read it now, but so there was no obvious dip then, it came later.
Okay, we can see if we can find overnight the later figures that you're referring to, Doctor. If we go to the next page, we can then get a sense of the location of sessions for the 1984-1985 period. So in the Lothians, we've got what's described as local sessions and sessions at firms, and the same for the other areas. So
yeah.
Local sessions would they be village halls, church halls, and the like?
Yes. Yes.
And then sessions at firms is when you go to workplaces and employees donate.
Yeah, that's right.
And then we can see reference to the naval base and army. Appears to be a very modest amount, but no, there's no army, but naval base attendances and donations are recorded for that year. And then we've got Edinburgh government departments, universities and colleges, firms. I think those are all probably fairly self-explanatory, as is Edinburgh Centre. What does Edinburgh District refer to? Do you know?
I think that will have been the rest, essentially. There were some sessions in sort of suburban areas which were organised, probably were in a church hall or something like that. The majority, obviously, of Edinburgh donors came to the donor centre. Those would be effectively community sessions within the Edinburgh area.
And we can see from the footnote 1 that the Rosyth Naval Base includes volunteers from HMS Caledonia and the Royal Naval Armament Depot, Crombie. Now, in terms of donor sessions that were held at workplaces or in village halls, church halls and the like, so other than at the centre, essentially, were there arrangements in place that would afford privacy or opportunities to discuss matters in confidence? Or was that something that it was difficult to achieve in those types of settings?
In most of them, it was extremely difficult to achieve. I mean, yeah, the team would go out, it was like a military operation, put up the beds, put up screens, but it was relatively unusual that we would have access to a separate room that could be used for a confidential interview. So basically the answer is no, confidentiality was not really provided.
May I just ask a question? When it comes to the army, was Redford Barracks still in operation at this time in Edinburgh?
As far as I know.
But was it a deliberate policy not to go to the army?
I honestly don't know. I never I can't remember ever having been asked about or addressing that question. and I can't understand from these figures why there appear to be 99 donors when attendances and donations. I don't quite understand those small numbers, but I don't recall that we ever did sessions at Redford Barracks, and I honestly don't know why.
In terms of sessions in workplaces, was any consideration given to the fact that employees might feel pressured to give blood in their workplace, that they might not be truly voluntary in the same way as someone who turns up at a village hall or at the centre might be?
To be honest, I don't recall being involved in any discussion about that, and I haven't certainly seen any documentation sort of expressing that concern. I think it is and would have been a perfectly legitimate concern, but we were still, I think, in a if I can put it this way, we're still slightly in the sort of wartime atmosphere of the transfusion service when very big priority was given to obtaining the donations, and possibly, well, not possibly, I think certainly less awareness. There was less awareness of these sort of issues, which we've now become acute since AIDS. We've now become acutely sensitive to.
Now, if we can look at a different document, WJSN 6666016. This is the 1977 version of the memorandum on the selection, medical examination and care of blood donors. We looked before lunch, Dr. McClelland, at the Edinburgh's own guide, which you produced in response to the inspection report and appended to your response to the inspection report in early 1983. Prior to the introduction of your bespoke guide, was this the guide, the memorandum that was in use in the South East Service?
To the best of my recollection, this was in use in the South East, yes.
Now, we've looked at this with other witnesses, so I don't propose to go through it in any kind of detail, but I just want to draw your attention to a couple of passages and then ask you some questions. Page 3, please, Sally, bottom of the page. So we see there the heading jaundice or hepatitis, and this explains that individuals with a history of jaundice or hepatitis or in whose blood anti-HBsAg is present may be accepted as donors, providing they've not suffered from jaundice or hepatitis in the previous 12 months, not been in house contact with hepatitis, or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of HBsAg when tested by a sensitive method. Now, I just draw attention to that. I'm going to come on to that issue very shortly. Before we do that, can we just go over the page? Page 4. If we look at paragraph 2A, this says the medical history should be coupled with a careful assessment of the donor's appearance. The experienced doctor can detect at a glance the potentially unsuitable donor, those of poor physique who are underweight, the debilitated, the undernourished, the mentally unstable, and those bearing the obvious stigmata of disease should not be bled. Now, just really by reference to that, I wanted to ask your perspective, Dr. McClelland, on really how much a doctor could tell about a donor and their suitability to give blood from this kind of assessment of appearance. You told the Penrose inquiry, we can look at it if you want, but I don't think we need to, that you gave some examples of some things that might be very obvious. Someone might see heavy tattoos on the arm or needle injection tracks, or someone who's obviously drunk. But leaving aside extreme cases or the case of someone who is, for example, extremely underweight, Was there much that a doctor could tell by the appearance of a donor, realistically?
I don't think so. I think this is just an assertion, really. I don't think there's, as you say, obviously gross underweight, gross malnutrition, or somebody who's clearly mad. That's easy enough. You don't need to be a doctor to spot those things. But I don't accept this assertion at all.
And then we can take that down. Thank you. But before I just come back to the question of hepatitis and jaundice, again, when you were talking to the Penrose inquiry, I think this was in the context of your evidence about prisons, but I think you were making points of more general application. You said how when the arm is presented to take the blood, the donor attendant might be able to see if there are needle tracks or a tattoo. Just a very basic question. Presumably that would be only the arm from which blood was taken. So you wouldn't necessarily, as a donor attendant, or indeed as a doctor present, see the other arm or any other part of the donor's body.
I think that's almost certainly true.
Now, in terms of hepatitis, we saw there the memorandum said that donors who had had hepatitis or jaundice over 12 months ago could, subject to the hepatitis B surface antigen test, donate. And that was a change of position from the position earlier in the 1970s. My understanding, the inquiry's understanding, is that change followed the advice in the second report of the advisory group looking at hepatitis B surface antigen. But it was left to the discretion of regional transfusion directors as to whether to do that or not. It wasn't a diktat from the government, whether in England and Wales or in Scotland. In Edinburgh, that practice was, as I understand it, adopted. So if you'd had hepatitis or jaundice more than 12 months ago, you were allowed to donate. Is that correct?
Well, certainly that is what is written in the first edition of the alphabetical guideline. I must confess I was very surprised when I read that, because that was not my recollection of our policy. But I guess if that's what's written in the selection guidelines, that must have been what we were doing at that time.
Because I think you said in your evidence to the Penrose inquiry and in your witness statement to this inquiry, you had some recollection that in some SNBTS services modified the policy, restricting acceptance to donors whose history of jaundice or hepatitis was when they were under the age of 12. That was your recollection? Yes,
well, I'm sure that was introduced in the South East. I mean, I would have to look through the successive guidelines, but I'm sure that was what I actually thought our policy was. And I do have a recollection of not so well, possibly in preparation for the Penrose inquiry, of looking at that original statement on accepting hepatitis after a year and thinking that's wrong. Although it was consistent with the decision of the advisory committee on hepatitis that they had specifically opened that option.
If we go to PRSE 0000271, please, Sally. And if we could go to page 24. So you'll see there, Dr. McClelland, halfway down the left-hand column, there's a letter. This is the Lancet, March 1980. Blood donors with history of jaundice. And it says in the first paragraph, the former policy of the Scottish Blood Transfusion Service was to reject as donors all persons admitting a history of jaundice. Lately, this policy has been modified to exclude only would-be donors with a history of jaundice within the previous 12 months. Donations are now accepted from most persons with a history of jaundice, provided that they are hepatitis B surface antigen negative upon routine testing. And then there's an investigation set out. I'm not going to go through the detail of that. If we go to the right-hand column, top of the right-hand column, we can see the authors of the letter are you and colleagues at the South East Regional Blood Transfusion Centre. So that would tend to suggest that as at 1980, the position was effectively consistent with the advisory group position that you could accept donors with a history of hepatitis or jaundice.
Yes, it clearly was. The slight concern, though, is that at that time, the tests for hepatitis B surface antigen were still not as sensitive as they are now. So, there would be, nowadays, now I would question whether this was wise without undertaking at least, a PCR test for hepatitis B or some additional testing, because we now know that there are some individuals who have late after an infection have very, very low levels of surface antigen, but that may possibly still be infectious. I think this was probably perfectly reasonable given the technology of the time, but possibly could be questioned now.
Well, I'll come on to the issues about hepatitis B tests and their sensitivity probably tomorrow. But simply as a matter of fact, then it appears that you could, as your alphabetical guide suggests, you could donate in the South East Scotland region, and that would suggest then that your recollection of this only applying to those whose history of hepatitis or jaundice was when they were under the age of 12 was not the policy in the South East.
I'm sure it became the policy later, but at the time that we're discussing, it would appear that it was not.
And then I just wanted to pick up on what you say in the last paragraph of this letter. We conclude that in the donor population of South East Scotland, a history of jaundice is not associated with an increased risk of HBsAg carriage, and that's on the basis of what you set out in the body of the letter. You say this is in agreement with findings in the west of Scotland reported by Dr. Follett and colleagues. The prevalence of antibody to hepatitis A in our region is similar in donors with and without a history of jaundice. And then this suggests that the viruses of non-A, non-B hepatitis may be a significant cause of jaundice in this population. So are we to understand that last sentence essentially as it reads, that you're identifying there that there may be those with non-A, non-B hepatitis, who had jaundice caused by non-A, non-B hepatitis? You obviously can't test for it specifically, or can't come on to the question of surrogate testing tomorrow, but they are nonetheless going to be donating.
Well, this was a speculative suggestion. One needs to say, and I'm sure it's in my evidence somewhere, but a history of jaundice, I'm sure other witnesses have said this as well, is a very imprecise piece of information. It may be that someone had neonatal jaundice, which is not a virological problem at all, was told about that in later life. They may have had, what the French would call a crise de foie and decided that it was jaundice when it wasn't. And some people don't actually really understand what jaundice means. So, yeah, it's a perfectly reasonable speculation, but it's not terribly measured, if I could put it that way.
Now, just finally on the issue those with a history of hepatitis or jaundice. Can I ask you to look at NHBT 0010-651_004. This is a recommendation of the Committee of Ministers of the Council of Europe, June 1983. I'm sure if we go over the page, you're familiar with it, Dr. McClelland. It was a recommendation amongst other things. We look first of all at the top of the page. In paragraph 1, the third bullet point is to provide all blood donors with information on AIDS, so that those in risk groups will refrain from donating, some form of leaflet, in other words. And then it says an example of an information leaflet for donors is appended. If we look down the page, this is the appended leaflet. Now, it's right to note this is one used by the American Red Cross, given as an example for services wishing to draw up their own information leaflet. I'm not going to go through the details of what it says about AIDS on that first page, but if we go to the next page, we can see at the top of the page, hepatitis, persons with a past history of viral hepatitis are deferred permanently. First of all, Dr. McClelland, did you become aware in 1983 of the Council of Europe recommendation?
I can't honestly remember. I probably was aware of them. But I have no specific memory of that.
Do you recall whether in 1983 there was any conscious consideration of changing the approach to persons with a history of viral hepatitis so that they would be deferred permanently?
It's certainly a matter that was discussed quite frequently, but I cannot honestly remember the nature or the timing of those discussions. I would have to refer to later versions of the donor selection guidelines to see whether we had, as I believe, changed this this recommendation or requirement. At the moment, I don't have a specific recollection of when it was changed.
Can we then look at PRSC 00031112? Oh no, that's the wrong reference. 3112, please, Sally. Thank you. So this is a letter from Dr. Cash. This is to Dr. Brooks, but it looks like it's at the bottom of the page. It says C, transfusion directors, which I take to mean copied to the transfusion directors en masse. But if we just look at the first paragraph of Dr. Cash's letter, he says this: one of the general points made by the Medicines Inspectorate was that in the SNBTS, the acceptance of a donor was largely a matter of chance. Clearly a gross exaggeration, but it has been well known for many years that the consistency between centres is less than desirable. Now, I think it's right, isn't it, that the Medicines Inspectorate didn't just inspect your centre and your service. They carried out inspections elsewhere in Scotland as well.
They did, but I'm not sure. I think the later inspections in Scotland actually followed the inspection and the initial inspection in Edinburgh.
Do you have any observations on Dr. Cash's own acceptance here, that it was well known and had been for many years that there was a less than desirable consistency between centres in Scotland?
Well, to be honest, I don't know on what he based that statement. I don't know how you would measure consistency of acceptance or rejection of a population of donors. The only the only number I can think of that he might have had in mind was the proportion of donors who were deferred or rejected. If that was much higher in one centre than the other, it might suggest that they were being more discriminating, or that they had, a particular person there who concentrated on a population of donors, felt they should be excluded. Largely a matter of chance. I think that's a rather unfair description, because, as I said this morning, it's an extremely difficult thing to decide if an individual who turns up to donate is sufficiently not healthy to bar them from donation. It's a challenge. It would be a challenge to anyone, even a very skillful clinician. So I don't know what is the basis. This implies that his statement implies that there are systematic differences between the centres, and I'm not aware of any evidence of that.
Would it be fair to say that Dr. Cash, because of his role as National Medical Director, would be more likely to have a sense of what was happening in other centres than you would? You'd have the expert knowledge of the South East Centre, but not necessarily a detailed understanding of what other centres were doing.
That's entirely true.
You referred a moment ago to rates of donors who were excluded or deferred. Were records kept in the South East Scotland Service of numbers of donors excluded and deferred?
Indeed, yes. In fact, I think on one of the documents you showed earlier, the SEBTA annual report, I think the figures are there in that table. Yes, it was an important number for us, because we worried always about whether the deferral rates were appropriate. If they were too high, there was a concern that we were not only losing the opportunity to collect blood, but also demotivating people, because rejection as a donor strongly predicts that they won't come back. And if they were too low, we worried that, maybe we were accepting people that we couldn't accept. So it was a constant debate and battle to try to do it better.
What, if any, systems or practices were in place to ensure that a donor who'd been excluded elsewhere could not give blood in your area?
That, as I said in my evidence, I think at the time I started work, that was not available. When we started, I started very rapidly to introduce the work to get eventually a computer system, first of all, for the South East, which then became a national system a system for all the centres in Scotland except, or much later, Glasgow took it on. When that system was operational, we introduced something which I recall was called the National Donor Register or something, which was expressly designed to fulfil that function. I have seen a reference to it in a document that I read quite recently, but unfortunately I can't remember which document it was, so I can't date that.
Dr. McClelland, we can check that again overnight. Like you, I've seen a reference to it and can't recall the date or where I saw it. I asked you this morning by reference to the guidance that you drew up on the selection of donors in response to the inspection report about the issue relating to those who had misused drugs. Just want to ask you to look at a later version of the national memorandum. Sorry, I can't read my own handwriting here. It is NHBT 0053225. Not got it on screen yet. So this is, again, the guidance for the selection, medical examination and care of blood donors. Now, Dr. McClelland, this is undated, but because of documentary references in it, can't be anything earlier than 1984, whether it's 1984 or later, I don't know. But if we just go to page 3, we can see here an alphabetical list, I think a shorter and less detailed one than the one in your own document that we looked at. But the third item, drug abuse, action, disqualify. So that's a fairly unequivocal statement of what should happen in relation to a donor who is believed to be a drug abuser. Are you able to assist us in understanding whether that became the practice in the southeast region, and if so, when? Given that what we saw this morning from the early 1983 document suggested that it wasn't the approach.
I honestly can't. I'm sure it did become the practice, but I can't say again without reference to documents. I can't tell you when. It was always a problematical thing to judge, and we did discover that there were people who honestly, told us they were not drug abusers, who turned out to be hepatitis C positive, and it transpired on full questioning that they had injected drugs perhaps once 20 years ago and did not consider themselves to be drug abusers. But I cannot give you an answer to your question, your specific question.
Now, the point you've just made, Dr. McClelland, perhaps might reinforce the importance of personal donor interviews, which we discussed this morning as having been introduced at a later stage. My note, but I need to check where it comes from, is that this was introduced in 1992. Whatever the precise date, what was the reason for not introducing that at any earlier stage? Was it simply a matter of resources?
That certainly would have been a significant part of it. I think that it was also there was an evolution, not just in the practice, but I think in our consideration of how to address what I've already said is an extremely difficult problem of how to get a sound assessment of a donor. Now, I cannot remember whether it was Dr. Gillen's initiative. I think it probably was. I certainly supported it. It had actually been considered at an earlier stage, because if you recall something we looked at this morning, there is a reference in my response to the 1982 inspector's report, in which I said we had tried introducing personal interviews. Admittedly, I think that was for all donors, and we couldn't. Basically, we clogged up the sessions to the point that we could not continue it. When it was introduced again by Dr. Gillen, it was for new donors only, partly for reasons of time. And I think I remember him saying that it was also, he felt it would be counterproductive if a donor was attending every 6 months and they were given the same interview 6 monthly. It wouldn't actually help and might put the donor off. And I felt at the time that was a perfectly sensible argument.
Now, I want to come on now to the question of prison donations. I'll deal with it, I hope, relatively shortly in light of the evidence you've already given on the topic. I'm not proposing to go to the documents which show the discrepancies in dates, but just for the benefit of those listening, I just want to read out the references and then ask you to confirm your understanding of the position. There is, as I know you know, because you've commented on in your written statement, that there's a an SNBTS directors meeting in March 1983, and the reference for the transcript is PRSE 40193, which suggests that sessions were held in penal institutions in all regions in Scotland, still at that stage. As I understand your evidence, you think that is incorrect in relation to the South East Scotland region.
I'm extremely certain that that is incorrect.
And then in terms of the date on which you believe the prison collection stopped in the South East region, again, I'm just going to read the references without going to the documents. PRSE 0002164 is a document on prison collection submitted by the SNBTS to the Penrose inquiry, which suggested that the last prison collection in the South East region was April 1980. But then PRSE 0002653, which is further evidence received by the Penrose inquiry, suggests and gives a specific date from you that the last donor session was the 18th of December 1981. And you think that's the correct date, as I understand it?
That is my recollection, as I explained this morning.
Now, you discussed in your evidence to Penrose why and how prison donations came to an end in the South East region. I'm not going to go through the details of that. We have your evidence to the Penrose inquiry, and you've said in your written statement that hasn't changed. So I think you've explained further one aspect of the evidence you gave to Penrose. But in terms of how it came about, is this right? Essentially, it was an issue raised with you by a newly appointed blood donor organiser. That's what led to the change.
Yes.
And in the rest of Scotland, the evidence submitted to the Penrose inquiry suggests that donations from prisons continued.
That is my understanding. Not for very long, but they did continue for some time. I think the west of Scotland was perhaps the last to stop. I think the others actually stopped rather quickly.
Yes, perhaps I will just show that because there's a question I want to ask on the basis of it. So it's PRSE 0002164. And if we go to page 8, please. So this is the document that contains for the South East the erroneous date of April 1980. But then we can see the dates, assuming them to be correct, for the other regions, give dates July 83, August 83, March 84, February 83, October 83. Now, once you'd taken the decision to no longer collect from prisons, did it occur to you to convey that to your fellow directors with a view to persuading them to do likewise?
Well, I certainly conveyed it to my fellow directors. Whether I did it formally or by letter, I think it's more likely that I reported our action at a meeting of the directors, which was a fairly usual way of sharing information. I can't claim that I made strenuous attempts to persuade the other directors to change their policy, because I think perhaps we've already discussed enough that I felt that would probably be actually counterproductive. Certainly wouldn't have been appreciated. They did not like their colleagues interfering with their patch, as it were.
You said to the Penrose inquiry you didn't recall any particular discussions with the Scottish Home and Health Department on the issue of prison collection.
No.
Does that surprise you that it's not an area in which they took an active, or apparently did not take an active interest?
Well, I mean, I didn't consult them. I just, as soon as I rather belatedly realized that we were still doing this, I just stopped it. I didn't feel any need to consult with the Home Health Department because I wasn't going to change my mind.
And do you recall any discussions with Dr. Cash on this particular issue?
No, not until after the event. I think I'm sure he would have been supportive.
And just want to check the reference for this, but you told the Penrose inquiry that at least with hindsight, you think prison collection should have stopped earlier than it did, and should, with the benefit of hindsight, have stopped really after 1975. Is that correct?
It's set out in paragraph 75 of his statement.
I'm sorry, I didn't catch the reference to 1975.
No, sorry, it's I'm talking across to you, I'm sorry. I was just referring counsel because she was wondering where the reference might be. To paragraph 75, I think it is, of your witness statement.
Yes, and the particular date you gave in your evidence to the Penrose inquiry, although it doesn't, I don't think the date is in your witness statement, was I think you accepted, albeit you said you were accepting it with hindsight, that prison blood shouldn't have been collected after 1975.
Well, I absolutely accept that, and I think probably it should never have been accepted, to be honest. But I mean, I have to freely admit that I was fairly new in the job. I was up to my ears in ghastly old buildings and all the rest of it, and I hadn't really internalized that we were still doing it until Mary Thornton came and talked to me, and at that point I just said, well, we've got to stop. But yes, I would be delighted if I could say now that we stopped immediately, or we'd never done it.
And then just one final question in relation to military collections. PRSE 0002258, please, Sally. This is an SNBTS meeting, December 1985. If we could just go to page 3. The second paragraph, the sentence that's underlined. Meanwhile, it was noted that the transfusion centres continued to visit US bases to collect blood, and it was agreed no change should be made meantime. Were there US bases from which blood was collected by the southeast region, to your knowledge?
No.
Now, I want to come next then, we can take that down, thank you, to your developing knowledge in relation to AIDS and then various actions you took in relation to the risk of AIDS. I think if we start at PRSC 40502, please. This is another, I think, joint SNBTS document submitted to the Penrose inquiry. I'm going to use it as a shorthand so that we don't necessarily have to go to all the underlying documents. So if we can go to page 8. And we can see top of the page, it refers to a report you'd prepared for an inquiry in Australia. And then it sets out a number of dates and references. So the SNBTS National Medical Director, Dr. Cash, that is, had drawn the attention of the SNBTS directors to the 1981 papers containing the first case reports. During early 1982, the CDC reports of similar cases among patients with haemophilia, and in early 1983, the first US interagency recommendations on prevention of AIDS were read by senior SNBTS personnel. And then there's a reference to the visit of Dr. Peter Foster in July 1983 to the World Federation of Haemophilia conference in Stockholm, and then to your own visit to the New York Blood Centre and attendance at the World Health Organization meeting on AIDS later in 1983. So that's really just a reminder of some of the dates. Just to then focus in on a couple of the specifics, in January 1983, at the SNBTS and Haemophilia Centre Directors meeting, Dr. Cash did, as this alludes to, indeed, draw attention of the attendees to recent publications concerning AIDS. We can look at it if necessary, but you describe it in your witness statement as a timely alert from Dr. Cash. And we know from other evidence the inquiry's heard, and you considered it, I think, in the course of your evidence to Penrose, that December 1982 was MMWR publication referring, amongst other things, to the San Francisco baby case.
Yep.
Putting all that together, and I'm trying to take it, as I say, relatively quickly because it's ground you went over in your evidence to Penrose. Is it right to say that as at the end of 1982 or the beginning of 1983, your view was that it was probable that AIDS was caused by a virus which could be transmitted by blood or blood products?
Absolutely. Yes.
Do you recall, other than whatever we might see in the minutes of those annual meetings with Haemophilia Centre directors, do you recall any discussions with clinicians using blood or blood products to try and make them aware of these risks? I'm really thinking here about the first half of 1983, Dr. McClelland.
To be honest, I don't recall. I was fairly actually focused on trying to decide what we could do about making our donors as safe as possible in the absence of a test. I'm sure I would have had, informal discussions with Dr. Ludlam, and it's very likely that other clinicians in certainly in the Royal Infirmary, who they often sort of came to chat to us about blood things, may well have raised it with me. Certainly if they did, I would have said, well, my take on this is that it's going to prove to be a transmissible infection, because I really didn't, I felt the evidence, despite the fact that there were numerous other theories ranging from sort of reasonable to bizarre, I felt that the evidence, particularly about the haemophilia, patients with haemophilia, was it was very hard to interpret it any other way, to be honest.
Now, I just want to ask you to look at two sentences in your witness statement with me, and then I want to ask you to elaborate upon them. So WITN 6666001, please, Sally. But first of all, page 95. Page 95, please, yes. Sorry, our system's on a go slow, Dr. McClelland. Yes, so paragraph 279, it's just the last half of that paragraph. You say this: in early 1983, AIDS was already a substantial problem in parts of the USA, but only a very few clinicians had seen AIDS patients in the UK. I think that transfusion personnel were occupied with many other challenges, and most took some time to realise the seriousness of this infection. And then the second paragraph I want you to look at, which is to similar effect, and then I can ask you about them both, is page 110, please. paragraph 321, bottom half of the page, you say, personally, I had no doubt that the evidence for an infectious agent being the cause was strong. I believe my medical colleagues in SEBTS shared this view, and I do not recall any discussions with them in which this interpretation was challenged. I do know that there was some reluctance in some quarters, including within the UK transfusion services, to acknowledge the gravity of what was emerging, and there was concern that any form of questioning of donors about their sexual habits or even raising the issue in printed information issued to potential donors could discourage donors from attending and lead to shortages of blood. Now, if we leave aside the concern about questioning and the issue of the leaflet, because we're going to look at that shortly, you say in these two passages that transfusion personnel occupied with many other challenges, most took some time to realise the seriousness of the infection. And then here you say you think there was a reluctance in some quarters, including within transfusion service, to acknowledge the gravity of what was emerging. Why was there that reluctance to face what was happening?
What I'm about to say has to be conjecture and perhaps personal opinion, but there was a belief in the sort of transfusion community, particularly those who were very much engaged with the blood donor and donation side of it, that blood donors were particularly worthy and meritorious population, and I think the thought that they could, in any sense, in the public mind, be linked with behaviour which was certainly subject of enormous prejudice, to put it politely, at that time, homosexual behaviour and also misuse of drugs. I think there was a deep-seated reluctance to accept that there was any kind of link between our lovely blood donors and those unpleasant habits. The other issue, of course, which is a more practical one, and this is not conjecture, is that there was very considerable concern and reluctance, I think described very well by Dr. Walford in her part of her witness statement. The transfusion directors in England were not at all enthusiastic about the idea of exposing donors to any information about the behaviours associated with, or possibly associated with, HIV. So I think there were at least two factors involved here.
And then just on that first passage we looked at, page 95, you said that you think transfusion personnel were occupied with many other challenges. In 1983, what other challenges were there that were more pressing than the emergence of a potentially lethal threat to the safety of the blood supply?
Well, I think looking at it from now, probably the answer is there weren't any, but that's perhaps conjecture on my part. But I certainly was very much aware that personally, as I said earlier, I had been up to the ears in trying to solve the problem of operating in a centre which was frankly awful. And that had taken a huge amount of time and effort and was a great source of worry. I really, perhaps I've been a bit I've overgeneralized too much in attributing that to other transfusion directors.
We can take the statement down, thank you. Now, in the documents that I know you've read for the purposes of your evidence, and some of them we'll look at, but in 1983 and 1984 there are then a number of discussions in relation to AIDS and what to do from the perspective of the transfusion service in that regard. Do you recall whether the cumulative risk of AIDS, non-A, non-B hepatitis and hepatitis B with a shared transmission route from the perspective of the blood service, whether that was considered in the assessment of risk and the assessment of what to do? Or did the focus become, in 83, 84, very much simply on AIDS?
I think it's probably correct to say that the focus for a time was very largely, if not exclusively, on AIDS. But we were aware, quite early on that there was a problem in the drug-using community, although it was not until 1985 when the very first commercial AIDS test became available and was being evaluated by our virology expert, Dr. Puther, that we discovered that there was a huge outbreak. Well, 85 patients in one particular part of Edinburgh, which was known to have a drug misuse problem, had all got AIDS, and probably from a single source over a very short time. And we already knew, one of the reasons their samples had been tested was because Dr. Puther, being a sensible virologist, reckoned he would look at samples that had been referred to him for hepatitis testing to see if he could find evidence of HIV there. So there was definitely a background awareness that these two things would certainly be associated with drug misuse if indeed AIDS was an infectious agent. But I think it would not be correct to say that the combined impact of three separate viruses was occupying us at the time, because we were dealing pretty effectively. We had pretty good tests for hepatitis B by that time. There was nothing actually that we could do, which we'll come back to, about non-A, non-B. And there was potentially a lot that we could do about HIV, or HTLV3 as it was then.
Now, of course, we know that in Scotland, a number of haemophilia patients were infected as a result of treatment with a domestic product, a PFC product,
Yes.
and infections that can't be attributable to commercial products. This may be a difficult question to answer, but it's a question I've been asked to ask you, Dr. McClelland.
Yes.
Looking at it now, do you think in Scotland, the sense that Scotland was, if not fully self-sufficient, then relatively self-sufficient, may have created a degree of overconfidence in the safety of the domestic, or the safety of the production of blood and blood products?
There was certainly a very widely held belief, and it's implicit in many documents. For example, the Council of Europe one that you showed a few moments ago, that blood from indigenous voluntary donors is the safest you can get. And I think we were optimistic that the frequency with which we would find evidence of an AIDS virus in our donors' blood would prove to be very low, because there was very little of the disease around at that point. We were some years behind the United States, and that actually proved to be the case. I think I've forgotten the gist of your question. Apologies.
The question was whether that the sense of relative self-sufficiency in Scotland, the knowledge that most patients, people with haemophilia, could be treated with domestic products, whether that created a degree of overconfidence in the safety.
Well, I don't know whether it was overconfidence or not, but yes, there was an optimistic belief, I think. I mean, certainly it came as a terrific shock to discover that actually our donors' blood had transmitted HIV to these patients. I think I used the words in my report to Penrose that I said something like I was surprised that it happened so soon, and he took me up on that. But I wasn't feeling totally confident that it couldn't happen. But I thought we had a very good chance of avoiding it, and we didn't avoid it.
And just unpicking, if I may, that by reference to perhaps elements of the population of the South East Scotland area, and in particular Edinburgh.
Yeah.
I think you've already alluded to the fact that Edinburgh was known to have a significant IV drug use problem, albeit that it's later that obviously you identify the number of people infected with HIV only when tests become available. But it would have been, is this right? It was known in 1983, 1984 that Edinburgh did have an IV drug use problem.
Well, it was certainly known. I mean, whether it was specifically known to me at that time or not, I don't know. I subsequently, very, very, very soon, early in 1982, I started to have dealings with Dr. Roy Robertson, who was the GP responsible for the practice in Muirhouse in the north of Edinburgh, where the HIV outbreak occurred later. But something that definitely was a factor in stimulating us to get engaged with the gay community in Edinburgh through the homosexual rights group was the fact that the Edinburgh Festival had for many years been a target of some of the newspapers as being a sort of gay fest. And there were headlines early in 1983, presaging the festival and calling Edinburgh the gay capital of the North or something like that. So there was a lot of publicity about homosexuality being a big issue in Edinburgh, which I think actually was probably not particularly true. I mean, I have no data, but that we felt that this could actually really backfire incredibly badly on the gay community and on the transfusion service if we didn't jointly try to tackle this problem. Because if it was true that blood from a gay person could transmit HIV, that would not only be a disaster for the patient, it would be a disaster for the transfusion service, and it would be potentially a catastrophe for the gay community, because they would be pilloried on this new ground.
And do you recall whether consideration was ever given at the time? And again, I'm really thinking about 1983, 1984, 1985 here, to the extent to which there was international travel to and from Edinburgh, in particular between Edinburgh and the States?
I think certainly absolutely that would have been a very important factor. Whether we actually factored that in or not, I can't remember. I mean, there was a huge amount of international travel from all over the world to the Edinburgh Festival, and as we now know, there was plenty of HIV in other countries as well.
Now, before we get on to the leaflets, which we'll do after the break, I just want to ask you about a couple of other measures or potential measures or strategies that could have been considered. The first, in relation to the treatment of patients with haemophilia, would be use of cryoprecipitate rather than concentrates. At least there's a short-term measure waiting for a test to become available or more to be known. Were you ever asked, either by Dr. Ludlam or his haemophilia director colleagues, or by Dr. Cash or by the SHHD to increase production of cryoprecipitate, at least on a temporary basis, so that there could be a short-term reversion to cryo rather than concentrate?
I have absolutely no recollection of that happening.
In terms of the practicalities, if that had been considered, your evidence to the Penrose inquiry was that it would have been possible to scale up production and produce large quantities of cryoprecipitate if that was required.
If it had been, felt sufficiently important to allocate an appropriate amount of finance, it could have been done very quickly. We would have had enormous support in certain communities, certain places that I knew of, already sort of thought about. We would have had enormous community support in doing that, which would have made it go very quickly.
And then just, I think, one final question before we break. Back to your witness statement, WITN 6666001, and if we could go to page 52. It's paragraph 148, and I just really wanted to pick up on what you say in the last sentence of paragraph 148. You say, even if more cryo had been available, I believe treatment using only cryo would not have been accepted by patients or clinicians due to the incidence of reactions to cryo infusion and the inconvenience of administration. Now leave aside, if we made the position of clinicians, in relation to the position of patients, you've told us already you weren't a haematologist. You presumably didn't have direct interactions with any haemophilia patients at this time.
I never really never did.
So
certainly not this time.
It's fair to say that the belief you set out here is entirely speculative, is it not?
It is. It's totally fair to say that.
And then, just as sorry.
It's not entirely speculative because I was aware of patients expressing in various ways the problems with cryo. So I didn't gain that impression directly from individual patients, but I was aware through some publications and things that some of the clinicians had said that patients also perceived this was a problem. But I accept the statement as, perhaps one that I, as a non-haemophilia treater, should not have made.
And as a matter of generality, common sense, whether patients would have been willing to accept cryoprecipitate over concentrate might well depend on the information they were provided with about the relative risks of those forms of treatment.
I think that's entirely true. However, at this time, if we're talking about 1983, we wouldn't have been able to tell the patients anything useful about the magnitude of the risk of HIV, because we simply didn't know. And as far as non-A, non-B hepatitis goes, gosh, we had the evidence from the from Sheffield, the biopsy studies done by, I've forgotten his name.
Professor Preston.
Preston, that's right. I'm not sure. I should be sure, but I'm not right now. How much we actually knew about the magnitude of the non-A, non-B risk in haemophilia patients getting concentrates at that time. As I say, I can't dig that information out of my head at the moment. But I think it might have been quite difficult to give patients a sort of meaningful quantitation of the relative risks of the two types of product.
but it wouldn't have been.
I don't know whether it was attempted by the clinicians.
Okay. In a sense, your evidence and my questions about it are we're both speculating because you weren't privy to any discussions between haemophilia clinicians and their patients in any event at the time.
I wasn't. I mean, I have to say that I say this slightly reluctantly, but the haemophilia patients were fairly jealously guarded. And sadly, Dr. Bolton, who was, as I've said, a very capable haematologist, really never had much opportunity to have direct dealings with the haemophilia patients in Edinburgh, which was a great sadness.
Sir, probably a good time for a break now.
Yes, I just want to ask one question first. We've been speculating about what you've been speculating with counsel and she with you about what might have been said to an AIDS patient by a haemophilia clinician, properly advising them as to the risks, and you were wondering what they might have known about the risks. Can I ask it a little bit more concretely? You thought there was a risk, did you not?
What I think I've said is
in general terms, a risk of a very serious injury being caused by people getting AIDS through blood.
What I said was that I was confident by that time that the AIDS clinical syndrome was the result of infection with an infectious agent, almost certainly a virus. That's a sort of general understanding based on evidence at that time was exclusively from the United States. Although I realized there had been a case in haemophilia in the UK, but I didn't know it right, at this precise time. So, yeah, I could have said there is a theoretical risk. I mean, I had to do quite a lot of lecturing about HIV early on because there were very few people who were interested in it. And one of the questions that I was always asked was, if I get a blood transfusion, can you tell me what the risk is? And I had to say, I don't know. And even when we introduced testing, they said, can you tell me that it's going to be 100% safe? And I said, I can't tell you that. I can tell you that the evidence we have is it's going to be jolly close to 100% safe. But does that mean that nobody ever can get infection from a blood transfusion? It does not mean that. And if you happen to be the 1 in a million or whatever, it's you that matters. So, you can be very reassuring, but you're still giving false reassurance to the one individual who actually cops it. I think this advice has to be couched very, very carefully.
Yes, well, thank you for that. We'll take a break now until 10 to 4.
Thank you, sir.
10 to 4.